Diarrhea, chronic Marie Alborum, MD, ed., MPH, MACP, FACG, AGAF Aliacon, MD, MPH. Basics: description: an increase in frequency of defecation, urgency, or decrease in stool consistency, typically greater than 3 loose stools per day, for greater than 4 weeks. 1. Abnormal stool form is the most important defining factor. Frequent defecation with normal consistency is termed pseudodiarrhea. 1. Etiologies include osmotic, secretory, malabsorptive, inflammatory, infectious, and hypermotility. Infectious causes of chronic diarrhea are uncommon in immunocompetent patients. Parasitic etiologies are more common than bacterial. Epidemiology: incidence difficult to estimate as definitions may vary from patient to patient, though it has been estimated that the average American has an episode of diarrhea every other year. Prevalence varies by etiology. About 6.6% of the U.S. population, 2, is affected. Etiology and pathophysiology: chronic diarrhea is typically the result of disturbances in luminal water and electrolyte balance within the intestine that causes increased water volume in the stool. Osmotic, fecal osmotic gap greater than 75 mosm/kg. 1. Carbohydrate malabsorption: disaccharides, including lactose monosaccharides, including fructose polyols, including sorbitol, xylitol, sucralose, and saccharin, common sugar substitutes, cannot be metabolized and create an osmotic gradient. Magnesium, phosphate, and sulfate ingestion: secretory, fecal osmotic gap 50 mosm/kg. 1,3. Alcoholism: bacterial enterotoxins, i.e., cholera, stimulant: laxative ingestion. Post-cholecystectomy: excessive intestinal bile salts cause choleretic diarrhea, often resolves in 6 to 12 months. Ileal bile acid malabsorption: ileal resection of 100 cm leads to choleretic diarrhea due to excessive colonic bile salts. Disordered motility: post-vagotomy diabetic autonomic neuropathy. Hyperthyroidism: neuroendocrine tumors, Vipoma, gastrinoma, somatostatinoma, carcinoid syndrome, metastatic medullary carcinoma of the thyroid, adrenal insufficiency. Hyperthyroidism: non-invasive infection, giardiasis, cryptosporidiosis, microscopic colitis, lymphocytic or collagenous, protein-losing enteropathy. Idiopathic secretory diarrhea malabsorption. 1,3. Celiac disease, Whipple disease, tropical sprue, giardiasis, chronic mesenteric ischemia, lymphatic obstruction. Short bowel syndrome, ileal resection of greater than 100 cm leads to insufficient bile salt concentrations in the duodenum for optimal fat absorption, leading to fat and fat-soluble vitamin malabsorption. Small intestinal bacterial overgrowth, pancreatic exocrine insufficiency, cystic fibrosis CF, chronic pancreatitis, inadequate bile acid production/secretion. Inflammatory. 1,3. Ulcerative colitis, Crohn's disease, microscopic colitis, lymphocytic or collagenous, diverticulitis, vasculitis, radiation enterocolitis, eosinophilic enterocolitis. Invasive or inflammatory infections, Clostridium difficile, Entamoeba histolytica, cytomegalovirus, tuberculosis, neoplasms, colon cancer. Lymphoma, villus adenocarcinoma. Hypermotility, normal fecal osmotic gap. 1. Irritable bowel syndrome, IBS, functional diarrhea. Drugs. 1,3. Adverse effect of greater than 700 drugs, most commonly, NSAIDs, PPIs, colchicine, metformin, digoxin, ACE inhibitors, beta blockers, neurogliptins, theophylline, antibiotics, SSRIs, antineoplasic agents. Factitious diarrhea, excessive laxative use. Herbal products, St. John's wort, echinacea, garlic, saw palmetto, ginseng, cranberry extract, aloe vera. Infectious. 1. Bacterial, C. difficile, Mycobacterium avium intracellulare. Viral, cytomegalovirus. Parasitic, Giardia lamblia, Cryptosporidium, Iosospora, E. histolytica helminthic, Strongyloides. Food allergies. 1. Genetics: celiac disease is associated with HLA-DQ2 and HLA-DQ8 haplotypes on major histocompatibility complex, MHC, Class II antigen-presenting cells. Inflammatory bowel disease, IBD, is polygenic. CF is caused by a mutation in the CF transmembrane conductance regulator, CFTR, resulting in abnormal exocrine gland secretions. Risk factors: osmotic excess ingestion of non-absorbable carbohydrates, lactose intolerance, celiac disease, secretory. 1. Post-surgical, extensive small bowel resection/ileal surgery, vagotomy, bile acid malabsorption, history of neuroendocrine disease, history of stimulant laxative abuse, dysmotility syndromes, malabsorptive CF, chronic alcohol abuse, chronic pancreatitis/pancreatic insufficiency, celiac disease, medications, i.e., or listed, acarbose, inflammatory IBD, NSAID use. Thoracoabdominal radiation, HIV/AIDS, antibiotic use, immunosuppressant therapy, hypermotility, psychosocial stress preceding infection, genetic predisposition, alert, diabetes mellitus and/or prior cholecystectomy both cause secretory and osmotic diarrhea. General prevention varies by etiology. Treat the underlying cause. Commonly associated conditions: extraintestinal manifestations of IBD include arthralgias, aphthous stomatitis, uveitis/episcleritis, erythema nodosum, pyoderma gangrenosum, perianal fistulas, rectal fissures, ankylosing spondylitis, and primary sclerosing cholangitis. Celiac disease is associated with dermatitis herpetiformis, type 1 diabetes, other autoimmune disorders, and IgA deficiency. Many patients with IBS have behavioral comorbidities. Latex food allergy syndrome, associated allergies to latex in banana, avocado, kiwi, and walnut. 1. Diagnosis: history, detailed history of symptoms, 1. Onset, pattern, and frequency of stooling, stool volume and quality, including presence of blood or mucus, travel history, antibiotic exposure, dietary patterns, current medications, family history, especially IBD or colorectal cancer, determine aggravating or alleviating factors, changes with oral intake or improvement with selective food avoidance, i.e., dairy products, alarm symptoms such as rectal bleeding/melena, unintentional weight loss, fevers, or nocturnal symptoms, skin changes, rashes, hives, arthritis, ocular problems, heat intolerance, polyuria/polydipsia, headache, fever, flushing, alcohol intake. Food allergies are rare, occurring in only 1–2% of adults. Consider in patients with hives. 1. Flatus and bloating are predominant features of carbohydrate malabsorption. 1. Prior surgery or radiation therapy. 3. History of systemic illness, endocrine, immunologic IBS or functional diarrhea by Rome. 4 criteria. 3. IBS, recurrent abdominal pain at least 1 day/week for past 3 months, symptoms greater than 6 months, greater than or equal to 2 of, related to defecation, associated with change in frequency of stool, associated with change in form of stool. Functional diarrhea, greater than or equal to 25% loose or watery stools without prominent abdominal pain or bloating for greater than 3 months, symptoms greater than 6 months. Physical exam. General, volume depletion, nutritional status, recent weight loss. 1. Skin, flushing, carcinoid, erythema nodosum, IBD, pyoderma gangrenosum, IBD, ecchymosis, vitamin K deficiency, dermatitis herpetiformis, celiac disease, hyperpigmentation, Addison disease. 1. Heat, iritis/uveitis, IBD, lid lag, hyperthyroid. Neck, goiter, hyperthyroid, lymphadenopathy, Whipple disease, cardiovascular, tachycardia, hyperthyroid, heart murmur, carcinoid syndrome. 3. Pulmonary, wheezing, carcinoid, abdomen, hyperactive bowel sounds, IBD, abdominal distension, IBD/IBS, diffuse tenderness, IBD/IBS, anorectal, anorectal fistulas, IBD, anal fissures, IBD, fecal impaction, overflow incontinence, extremities, arthritis, IBD, neurologic, tremor, hyperthyroid, differential diagnosis. See etiology and pathophysiology. commonly associated conditions, and risk factors. Diagnostic tests and interpretation. Initial tests. Lab, imaging, test patients with alarm symptoms or persistent symptoms and no identifiable cause. Blood, CBC, electrolytes, Mg, P, Ca, total protein, albumin, thyroid stimulating hormone, free T4, erythrocyte sedimentation rate, C-reactive protein, IgA anti-tissue transglutaminase, TTG, iron studies, 1,2, stool, WBCs or fecal calprotectin, preferred, culture, ova and parasites, Giardia stool antigen, C. Difficile toxin, electrolytes, occult blood, osmolality, qualitative fecal fat, Sudan stain, 1, fecal osmotic gap equals 290 mosm/kg2, Na feces plus K feces, CT or MRI to evaluate the structure of the GI tract, i.e., IBD, malignancy, chronic pancreatitis, 1, follow-up tests and special considerations. Celiac disease, anti-endometrial antibody IgA, anti-TTG IgA, anti-gliadin, AGA, IgA, serum IgA. 10% of celiac patients have IgA deficiency may cause false negative results. Chronic pancreatic insufficiency, fecal elastis and chymotrypsin, 1, C. Protein-losing enteropathy, fecal alpha-1 antitrypsin, 1, C. Microscopic colitis, mucosal biopsy from colon, 3, C. Carbohydrate malabsorption, fecal pH, 7.0, and hydrogen breath test. Small bowel overgrowth, hydrogen breath test. Recent hospitalization or antibiotics, C. Difficile toxin HIV ELISA, Iosospora/Cryptosporidium stains, 1, C. Consider testing for protozoa, atypical infections, strongyloides, and tropical sprue in travelers and migrants. Of endemic areas, 1, C. Allergy testing, 1, C. Laxative abuse, stool osmolality, osmotic gap, 3, C. Neuroendocrine tumor, 3, C. Serum, chromogranin A, VIP, gastrin, calcitonin urine, 5 HIAA, histamine. Diagnostic procedures / other ileocolonoscopy with biopsies, IBD, microscopic colitis, CMV colitis, and colorectal neoplasia. Flexible sigmoidoscopy, especially if pregnant, with comorbidities, or if left-sided symptoms predominate, tenesmus and urgency. Esophagogastroduodenoscopy, EGD, with small bowel biopsies if malabsorption is suspected. Celiac, Giardia infection, Crohn disease, eosinophilic gastroenteropathy, Whipple disease, intestinal amyloid, pancreatic insufficiency. Capsule endoscopy if further evaluation of small bowel is needed. Upper GI series with small bowel follow-through. CT or magnetic resonance, MR, enterography, 1, test interpretation. Celiac disease, Marsh classification, intraepithelial lymphocytosis, crypt hyperplasia, villus atrophy. Crohn disease, cobblestoning, linear ulcerations, skip lesions, non-caseating granulomas. Ulcerative colitis, crypt abscesses, superficial inflammation. Lymphocytic colitis, increased intraepithelial lymphocytes, increased inflammatory cells within the lamina propria. Normal mucosal architecture. Melanosis coli suggests laxative abuse. 1. Treatment. General measures. Volume resuscitation if necessary. Electrolyte replacement as needed if stable. Treatment is generally outpatient. 1, C. Medication. First line based on underlying cause, lactose intolerance, lactose-free diet. Post-cholecystectomy or ileal resection, cholestyramine or cholestyramine 2 to 16 g/day. Po-divided bid. Diabetes, glucose control. Hyperthyroidism, methimazole 5 to 20 mg/day. Po, propylthia uracil, PTU, 100 to 150 mg/day. Po-divided, thyroid ablation. C. Difficile, vancomycin 125 mg po Q6H or metronidazole, Flagyl, 500 mg po Q8H or fidaxomicin 200 mg po bid-G. Lamblia, metronidazole 250 mg po Q8H. Nitazoxanide 500 mg po Q12H. 1. A Whipple disease. Ceftriaxone 2 grams 4 for 14 days, then trimethoprim and sulfamethoxazole. Bactrim DS. 160/800 mg po bid for 1 to 2 years. Small intestinal bacterial overgrowth. Rifaximin 550 mg po bid. Fluoroquinolones 250 to 750 mg po bid. Metronidazole 500 mg po Q68H. Penicillins pancreatic insufficiency. Enzyme replacement HIV/AIDS. Antiretroviral therapy microscopic colitis. Budesonide 9 mg/day po. Mesalamine 800 mg po TID. Bismuth subsalicylate. Pepto-Bismol. 786 mg po TID IBD. 5-aminosalicylic acid. 5-ASA. Corticosteroids. Short-term only. Antibiotics. Short-term only. Immunomodulators. 6-mercaptopurine 6-MP. Azathioprine. Methotrexate. Anti-TNF therapy. Infliximab. Adalimumab. Certolizumab. Neuroendocrine tumor. Octreotide 100 to 600 g/day SC. 1. C. Celiac disease. Gluten-free diet. Wheat/barley/rye avoidance. IBS diarrhea predominant. Rifaximin 550 mg po bid. Aloestrin 0.5 to 1 mg po bid. Peppermint oil. Iloxidolin 100 mg po bid. 1. C. Symptom relief. 1. C. Loperamide 4 to 8 mg/day po divided diphenoxylate atropine 1 to 2 tabs po bid. QID fiber supplementation. Bismuth subsalicylate 525 to 1050 mg every 0.5 to 1 hour. Max dose 4200 mg/day. 1. C. Issues for referral to a gastroenterologist for suspected inflammatory diarrhea. Surgery/other procedures. Resection of neuroendocrine tumors. Intestinal resection for medically refractory IBD. Fecal transplant for recurrent C. difficile infection. Admission, inpatient, and nursing considerations. Consider inpatient hospitalization if patient is hemodynamically unstable, has severe electrolyte abnormalities or acute kidney injury, or is unable to tolerate oral intake. Ongoing care. Diet. Elimination diet. Avoid gluten-containing foods, non-absorbable carbohydrates, lactose-containing products, and food allergens depending on etiology of diarrhea. Low FODMAP. Fermentable oligosaccharides, disaccharides, monosaccharides, and polyols. Diet helps symptoms in up to 75% of IBS patients. 1. High carbohydrate intake and obesity have been linked to chronic diarrhea. 2. Patient education. Diarrhea is generally defined as 3 or more loose bowel movements per day for over 4 weeks. Wide variation in normal bowel habits restrict colon stimulants. Base specific education and dietary changes on underlying etiology. Prognosis varies according to etiology. Complications. Fluid and electrolyte abnormalities. Acute kidney injury. Malnutrition. Anemia. Unintentional weight loss. Malignancy. Colon cancer in IBD, small bowel cancer in celiac disease and Crohn disease, lymphoma with IBD therapies, infection with immunomodulator, biologic, and corticosteroid therapies for IBD.